a Wikividi Documentaries production. Don't forget to like and subscribe. Enjoy. Kawasaki disease. Kawasaki disease, also known as mucocutaneous lymph node syndrome, is a disease in which blood vessels throughout the body become inflamed. The most common symptoms include a fever that lasts for more than 5 days not affected by usual medications, large lymph nodes in the neck, a rash in the genital area, and red eyes, lips, palms or soles of the feet. Other symptoms include sore throat and diarrhea. Within 3 weeks of the onset of symptoms, the skin from the hands and feet may peel. Recovery then typically occurs. In some children, coronary artery aneurysms may form in the heart after 1-2 years. The cause is unknown. It may be due to an infection triggering an autoimmune response in those who are genetically predisposed. It does not spread between people. Diagnosis is usually based on a person's signs and symptoms. Other tests such as an ultrasound of the heart and blood tests may support the diagnosis. Other conditions that may present similarly include scarlet fever and juvenile rheumatoid arthritis. Initially, treatment is typically with high doses of aspirin and immunoglobulin. Usually with treatment, fever resolves within 24 hours, and there is a full recovery. If the coronary arteries are involved, ongoing treatment or surgery may occasionally be required. Without treatment, coronary artery problems occur in up to 25% and about 1% die. With treatment, the risk of death is 0.17%. Kawasaki disease is rare. It affects between 8 and 67 per 100,000 people under the age of 5, except in Japan where it affects 124 per 100,000. It is much less common after the age of 5. Boys are more commonly affected than girls. The disorder was first described in 1967 by Tomisaku Kawasaki in Japan. Signs and symptoms. Kawasaki disease often begins with a high and persistent fever that is not very responsive to normal treatment with paracetamol or ibuprofen. It is the most prominent symptom in Kawasaki disease, is a characteristic sign of the acute phase of the disease, is normally high, is remittent, and is followed by extreme irritability. Recently, it is reported to be present in patients with atypical or incomplete Kawasaki disease. Nevertheless, it is not present in 100% of cases. The first day of fever is considered the first day of illness, and the duration of fever is on average 1 to 2 weeks. In the absence of treatment, it may extend for 3 to 4 weeks. Prolonged fever is associated with higher incidence of cardiac involvement. It responds partially to antipyretic drugs and does not cease with the introduction of antibiotics. However, when appropriate therapy is started, intravenous immunoglobulin and aspirin, the fever is gone after 2 days. Bilateral conjunctival inflammation was reported to be the most common symptom after fever. It typically involves the bulbar conjunctiva, is not accompanied by suppuration, and is not painful. It usually begins shortly after the onset of fever during the acute stage of the disease. Anterior uveitis may be present on slit lamp examination. Iritis can occur, too. Choratic precipitates are another eye manifestation. Kawasaki disease presents with set of mouth symptoms. The most characteristic changes are the red tongue, swollen lips with vertical cracking and bleeding. The mucosa of the mouth and throat may be bright red, and the tongue may have a typical strawberry tongue appearance. These mouth symptoms are caused by the typical necrotizing microvasculitis with fibrinoid necrosis. Cervical lymphadenopathy is seen in 50% to 75% of people, whereas the other features are estimated to occur in 90% of patients, but sometimes it can be the dominant presenting symptom. According to the definition of the diagnostic criteria, at least one impaired lymph node greater than or equal to 15 mm in diameter should be involved. Affected lymph nodes are painless or minimally painful, non-fluctuant, and non-suppurative. Erythema of the neighboring skin may occur. Children with fever and neck adenitis who do not respond to antibiotics should have Kawasaki disease considered as part of the differential diagnoses. In the acute phase of the disease, changes in the peripheral extremities can include erythema of the palms and soles, which is often striking, with sharp demarcation and often accompanied by painful, brawny edema of the dorsa of the hands or feet. This is why affected children frequently refuse to hold objects in their hands or to bear weight on their feet. Later, during the convalescent or the subacute phase, desquamation of the fingers and toes usually begins in the perongual region within 2 to 3 weeks after the onset of fever and may extend to include the palms and soles. Around 11% of children affected by the disease may continue skin peeling for many years. 1 to 2 months after the onset of fever, deep transverse grooves across the nails may develop, and occasionally nails are shed. The most common skin manifestation is a diffuse maculopapular erythematous rash, which is quite nonspecific. The rash varies over time and is characteristically located on the trunk. It may further spread to involve the face, extremities, and perineum. Many other forms of cutaneous lesions have been reported. They may include scarlatiniform, papular, urticariform, multiform-like erythema, and purpuric lesions. Even micropustules were reported. It can be polymorphic, not itchy, and normally observed up to the 5th day of fever. However, it is never bullous or vesicular. In the acute stage of Kawasaki disease, systemic inflammatory changes are evident in many organs. Joint pain and swelling, frequently symmetrical, and arthritis can also occur. Myocarditis, diarrhea, pericarditis, valvulitis, aseptic meningitis, pneumonitis, lymphadenitis, and hepatitis may be present and/or manifested by the presence of inflammatory cells in the affected tissues. If left untreated, some symptoms will eventually relent. But coronary artery aneurysms will not improve, resulting in a significant risk of death or disability due to myocardial infarction. If treated quickly, this risk can be mostly avoided and the course of illness cut short. Other reported non-specific symptoms include cough, rhinorrhea, sputum, vomiting, headache, and seizure. The course of the disease can be divided into 3 clinical phases. The presentation between adults and children differs, as adults' neck lymph nodes are more affected, hepatitis, and arthralgia. Some people have atypical presentations and may not have the classical symptoms. This occurs in particular in young infants. Those people are especially at higher risk for cardiac artery aneurysms. Cardiac. The heart complications are the most important aspect of Kawasaki disease. It is the main cause of heart disease acquired in childhood in the United States and Japan. In developed nations, it appears to have replaced acute traumatic fever as the most common cause of acquired heart disease in children. Coronary artery aneurysms occur as a sequela of the vasculitis in 20–25% of untreated children. It is first detected at a mean of 10 days of illness, and the peak frequency of coronary artery dilation or aneurysms occurs within 4 weeks of onset. Aneurysms are classified into small, saccular, and fusiform aneurysms usually develop between 18 and 25 days after the onset of illness. Even when treated with high-dose IVIG regimens within the first 10 days of illness, 5% of children with Kawasaki disease develop, at the least, transient coronary artery dilation and 1% develop giant aneurysms. Death can occur due either to myocardial infarction secondary to blood clot formation in a coronary artery aneurysm or to rupture of a large coronary artery aneurysm. Death is most common 2 to 12 weeks after the onset of illness. Many risk factors predicting coronary artery aneurysms have been identified, including persistent fever after IVIG therapy, low hemoglobin concentrations, low albumin concentrations, high white blood cell count, high band count, high Sp concentrations, male sex, and age less than 1 year. Coronary artery lesions resulting from Kawasaki disease change dynamically with time. Resolution 1 to 2 years after the onset of the disease has been observed in half of vessels with coronary aneurysms. Narrowing of the coronary artery, which occurs as a result of the healing process of the vessel wall, often leads to significant obstruction of the blood vessel and lead to the heart not receiving enough blood and oxygen. This can eventually lead to heart muscle tissue death, caused by thrombotic occlusion in an aneurysmal, stenotic, or both aneurysmal and stenotic coronary artery is the main cause of death from Kawasaki disease. The highest risk of ME occurs in the first year after the onset of the disease. ME in children presents with different symptoms from those in adults. The main symptoms were shock, unrest, vomiting, and abdominal pain. Chest pain was most common in older children. Most of these children had the attack occurring during sleep or at rest, and around 1/3 of attacks were asymptomatic. Valvular insufficiencies, particularly of mitral or tricuspid valves, are often observed in the acute phase of Kawasaki disease due to inflammation of the heart valve or inflammation of the heart muscle-induced myocardial dysfunction, regardless of coronary involvement. These lesions mostly disappear with the resolution of acute illness, but a very small group of the lesions persist and progress. There is also late-onset aortic or mitral insufficiency caused by thickening or deformation of fibrosed valves, with the timing ranging from several months to years after the onset of Kawasaki disease. Some of these lesions require valve replacement. Other Kawasaki disease complications have been described, such as aneurysm of other arteries, aortic aneurysm, with a higher number of reported cases involving the abdominal aorta, axillary artery aneurysm, brachiocephalic artery aneurysm, aneurysm of iliac and femoral arteries, and renal artery aneurysm. Other vascular complications can occur, such as increased wall thickness and decreased distensibility of carotid arteries, aorta, and brachioradial artery. This change in the vascular tone secondary to endothelial dysfunction. In addition, children with Kawasaki disease, with or without coronary artery complications, may have a more adverse cardiovascular risk profile, such as high blood pressure, obesity, and abnormal serum lipid profile. Gastrointestinal complications in Kawasaki disease are similar to those observed in Henoch-Schönlein purpura, such as intestinal obstruction, colon swelling, intestinal ischemia, intestinal pseudo-obstruction, and acute abdomen. Eye changes associated with the disease have been described since the 1980s, being found as uveitis, iridocyclitis, conjunctival hemorrhage, optic neuritis, amaurosis, and ocular artery obstruction. It can also be found as necrotizing vasculitis, progressing into peripheral gangrene. The neurological complications per central nervous system lesions are increasingly reported. The neurological complications found are meningoencephalitis, subdural effusion, cerebral hypoperfusion, cerebral ischemia and infarct, cerebellar infarction, manifesting with seizures, chorea, hemiplegia, mental confusion, lethargy and coma, or even a cerebral infarction with no neurological manifestations. Other neurological complications from cranial nerve involvement are reported as ataxia, facial palsy, and sensory neural hearing loss. Behavioral changes are thought to be caused by localized cerebral hypoperfusion, can include attention deficits, learning deficits, emotional disorders, and internalization problems. Causes. As the cause of Kawasaki disease remain unknown, the illness is more accurately referred to as Kawasaki syndrome. Its cause is widely hypothesized to involve the interaction of genetic and environmental factors, possibly including an infection in combination with genetic predisposition to an autoimmune mechanism. The specific cause is unknown, but current theories center primarily on immunological causes. Evidence increasingly points to an infectious cause, but debate continues on whether the cause is a conventional antigenic substance or a superantigen. Researchers at Boston Children's Hospital reported, some studies have found associations between the occurrence of Kawasaki disease and recent exposure to carpet cleaning or residence near a body of stagnant water. However, cause and effect have not been established. Other data show a clear correlation between Kawasaki disease and tropospheric wind patterns. Winds blowing from Central Asia correlate with Kawasaki disease cases in Japan, Hawaii, and San Diego. This association with tropospheric winds has been shown to be modulated at seasonal and interannual timescales by the El Niño Southern Oscillation phenomenon, further indicating the agent responsible for the disease is a wind-borne pathogen. Efforts are underway to identify the suspected pathogen in air filters flown at altitude above Japan. An association has been identified with an SNP in the ITPK gene, which codes an enzyme that negatively regulates T-cell activation. Regardless of where they are living, Japanese children are more likely than other children to manifest the disease, which suggests genetic susceptibility. The HLA-B51 serotype has been found to be associated with endemic instances of the disease. Brought to you by Wikividi Documentaries. Would you like to know more?